Okay, good afternoon, everyone. Thank you all for coming. My name is Lorraine Oriokot, and I'm going to present Subacute Sclerosing Panencephalitis, which is a chronic complication of measles. So this is an outline of my presentation. Subacute Sclerosing Panencephalitis is a rare progressive neurological disorder that's caused by persistent defective measles virus infection of the central nervous system. In terms of epidemiology, SSPE declines with declining incidence of primary measles infection, which makes sense because it's a complication of the primary measles infection. Sahal et al. Found that the annual incidence was 21 per million population in India, in comparison with 2.4 per million population in the Middle East. SSPE has been found to occur in about 1 in 100,000 people who actually have primary measles infection. So what are the risk factors for SSPE? One is a measles infection at an early age. So children less than 2 years who get measles are actually at risk of developing SSPE later on. And this will be primarily in adolescence or later on. And this was evident in our child, who Dr. Atuta presented, who had a measles infection at 18 months. The male to female ratio for SSPE is 2:1 to 3:1, so showing that it's more common in males, whereas we know that primary measles infection has no gender disparity. Rural habitation is also a risk factor. Children who have greater than or equal to 2 siblings, which was the case in our patient who has 5 siblings, and overcrowding. And these factors are thought to be sort of signifying an intense primary measles infection, which puts you at a risk for the SSPE. Also, a close temporal relationship with another infection close to the primary measles infection. So here particularly EBV infection and also parainfluenza infection, parainfluenza type 1. In terms of pathogenesis, the SSPE occurs when you have defective measles virus persisting in the CNS. So what happens is you have your primary infection, the person has measles in their body, and during this, the viremia, the initial viremia, you get entry of the measles virus into the CNS, and this is through the endothelial cells. Now, when the measles virus gets there, because of the interaction between the virus and the immature immune system or the defective immune system, you have alteration in the structure of the virus. And as a result, the virus is able to persist within the neurons because it's hidden away from the immune system. And after a long period, they say usually between 7 to 10 years, you then have a reactivation of the virus with invasion of other cells, okay? So what happens? You basically have it persisting in the cortical cells. However, later on, it invades the basal ganglia, and it can go deep within the basal ganglia, and this is the reason for the abnormal movements. The clinical features of SSPE are divided into 4 stages with increasing severity. So in stage 1, you have subtle changes in the child. So a child could just seem to become clumsy. So as Dr. Atuta presented, she started to become forgetful. Her mother would send her for something, and she would get there and she would forget, what have they sent me for, and come back. And also, concentration in school becomes a problem. So these children start to decline in their performance at school, which can be attributed to many other things and can often go undetected. Stage 2 is characterized by the development of the severe myoclonus, which initially involves only one group of muscles, but progressively goes on to involve other muscles, and eventually involves all the muscles of the trunk and all the limb muscles, such that this child is no longer able to function. In stage 3, in which you have the defective measles virus going deeper into the basal ganglia, this is when you get the chorioathetosis, immobility, lead pipe rigidity, and eventually these children will go from dementia to stupor, and finally to coma. Stage 4, which is the last and the most severe stage, is characterized by involvement of the respiratory centers, the cardiovascular centers, in the medulla and the pons, and this will eventually result in death. To say a bit about the cause, whereas it's termed as subacute sclerosing panencephalitis, it can take a variation of causes. So it can be acute, in which the patient will develop symptoms and die within 3 months, or it can be subacute, or it can be chronic. So it all depends. The diagnosis of SSPE is made based on identifying that the presentation of the child is compatible with the clinical course described for SSPE, and you need at least one supporting finding. For example, if you have measles antibody detected in the CSF, if you have the characteristic EEG findings, which we saw in our patient, or if you have the typical histological findings, and this may be either on biopsy or on postmortem examination. Previously, it was thought that you had to do a biopsy for every patient in whom you suspected SSPE, but that is no longer true, as we have this new criteria. The investigations that can be done, you require a CSF analysis, which we are undertaking in our patient, and here you want to demonstrate the elevated titers against the measles virus. That's IgG and IgM, because this now becomes like an acute on chronic illness. The EEG findings, as Dr. Tuta described them, are seen in the myoclonic phase. And in this patient, while they were doing the EEG, they also administered diazepam, which makes the findings more evident. And they're described as suppression burst episodes, which Dr. Tuta described very well. Yeah. So it basically means you have sort of flattening of the EEG with spikes. So it's the burst with suppression. I hope that's clear. So the CT scan in early stages may actually be normal. However, later on, you'll see small ventricles with obliteration of the sulci due to cerebral edema, which we also had in our patient. The management of SSPE is largely supportive because there is usually not much you can do. And so it's basically to control the myoclonic jerks, which are very disturbing for these patients. So you'll try out carbamazepine initially, which is available to most of us, and then you'd go on to sodium valproate, after which you'd go on to clonazepam, which is where we are at with our patient. And she's controlled, she's well controlled on the clonazepam. Baclofen is also used in the later stages. For example, in stage 3, where you get a lot of spasticity, it's helpful. Now, certain studies have found that drugs, isoprenosine, which is an antiviral drug, is actually a little bit effective in these children, and it can be used with intraventricular interferon. So in studies done with this drug, they found that 30 to 34% of the children who received this drug actually showed remission. However, the problem is this drug is very expensive, and once you develop remission to it, you need to be on it for the rest of your life. The prognosis in SSPE is quite poor. The outcome is nearly fatal in almost all the cases, and most children will die in an average of 1 to 3 years after the onset of symptoms. So, in conclusion, I think the most important thing I learned about this case and this presentation and researching it was that prevention is really better than cure. And that means basically primary measles prevention is the most important thing we can do for these children and even for our own children. So I guess that's the thing. Immunize, immunize, immunize. Thank you.